this computer. Okay, so yeah, today we're going to talk about how we reactivate the immune system, how we polarize the immune system to M1 and Th1, how we also help to change the tumor microenvironment in a way it become a hostile environment for cancer. And we're going to focus mainly on phosphatidylserine suppressive. Is there an echo? All right, so no more.
Yes, we had an echo.
We have an echo, right? Let me see if I can get this echo out. Okay, what about now? No echo, right? Okay, great. So yes, let me okay, and also we're gonna talk about the antibody mediated phosphatidylserine blockade activates the immune system and how that happened and all the mechanism behind the immune suppression effect of phosphatidylserine. So let's go and see the hallmark of cancer here. In order for the cancer to emerge and become cancer from normal cells, so those cells to become cancer, they have to resist death, right? So that's mean their apoptotic genes are being mutated, where they don't respond to the external environments, they don't get stimulated, and that's mean they will be surviving all the signal that induce the cells to die. Especially we know the cells when they grow, they're supposed to die, but sometimes those cells they don't because the mutation that happened in apoptotic genes, and that leads to those cells to resist death and that turn those cells into cancer. The other thing is that for the cancer to emerge from the normal cells and become cancer, and cancer needs to be able to survive, the cancer starts to secrete all these chemicals to create that microenvironment that helps them to grow, and part of that favorable microenvironment is stimulating the blood vessels to grow. So in order for those cancer to feed, so they start secreting all those chemicals that helps to stimulate the growth of the blood vessels, right? Like VGF. That's one of the way, and then they start over secreting it in amount that then you'll see that cancer is very rich with blood vessels induced by the tumor as they are secreting those chemicals to induce the proliferation and the growth of the blood vessels. Also, in order to the cancer to emerge out of normal cells, they have to be dividing nonstop, and so there is genes for that, where they control the cell cycle. Those are being mutated, and when they're mutated, that's mean they are able to grow unstopped, and that's what's happening to those genetic mutation to those cells, and that turns those cells into cancer. So enabling replicating, and they become immortal. So normal cells, they have signals, they respond to it, that stops them from dividing more than the normal limit that's being determined by their genetic makeups. But if there's mutation there in those proliferative genes, oncogenes we call them, then they start dividing nonstop, and there's no response to any external stimulus that stops them from dividing and growing, and that leads to cancer. Also, those cancer, in order for them to grow and invade the surrounding normal tissue, they have to evade the immune system, and so they start secreting all this chemical to suppress the immune system and turn off the cytotoxic T cells. And we're gonna learn that in the coming slide, how the tumor are secreting immune suppressive signals that will turn off the immune system or polarize the immune system away from Th1/M1. And also, the cancer has to be secreting chemicals that would help to break down the surrounding tissues so they can invade the surrounding tissues. So they secrete a lot of enzymes that will break down the surrounding tissues so they can grow and spread and metastasize to other area of the body and able to implant into other organs of the body. And that will lead to metastasize. So you have to have that capability. And the cancer will start all this chemical secreting all those chemicals that lead them to metastasize and move into other tissues and implant into other tissues by secreting chemicals that break down the surrounding tissues by and also they start secreting chemicals to even attract more of those cancer cells, and so you will end up having metastasis. Those are the way that the cancer can really flourish and grow and take over the body. The other thing is that the cancer also needs to find a way to, as I said, to avoid immune destruction, right, and evade the immune system. And so they start secreting chemical that suppress the immune system or change the microenvironments so that favor the growth of the tumor or polarize the immune system into away from Th1/M1. That's mean into M2, M17, Tregs. And all of this will help to turn off the immune system and allow the cancer to grow and proliferate and divide and take over the body. So yes, those tumors, they will promote inflammation, but what kind of inflammation? Not the inflammation that destroy the cancer, the inflammation that's mediated by interleukin-6 and Th17 and Th2, which will not destroy the cancer. In fact, it will suppress the immune cells that you need to kill the cancer, which is Th1 and M1. And those cytokines actually will suppress the immune system that we need to destroy the cancer. So they shift the immune system away from Th1/M1. So you can see inflammation, but you will see neutrophil, and you will see mast cells. So, but those neutrophil and mast cells, they don't do much in destroying the cancer. So that's how the tactic of the cancer is polarizing the immune system away from Th1 and M1. And yes, you would have inflammation, but those inflammation are not cancer destructive. In fact, they are cancer promoting cancer. Again, you also need to have mutations in those genes, especially the genes of the pro-oncogenes, so they can divide and stop, and they become immortal. And also the genes of apoptosis, which is responsible to induce apoptotic and kill those cells. They will be mutated, so they will not die, and they proliferate and divide non-stop. The other thing is that about the cancer, in order for the cancer to survive and grow, and they need to create a signal that will stimulate those cancer cells to divide all the time, nonstop. And we find out in the cancers that they have their free radicals level is higher than normal cells, because those apoptotic genes of the cancer do respond to higher free radical level, and they, especially we call them the proliferative genes, the oncogenes, and they start dividing unstopped, because those signals that stimulate those oncogenes, which are the free radicals, are constantly produced by this dysfunction mitochondria. So they make the mitochondria leaky and release free radicals enough to stimulate the cancer cells to divide nonstop. All right, so you will see mitochondrial dysfunction, leaking of free radicals, enough to keep those cancer cells to divide and nonstop. And one of the way to kill those cancer is to what we call inactivate the mitochondria and destroy them, or we can activate them, and then once they've been active, they will be inducing the mitophagy. So there's two ways. Like if we give them QQ10, the QQ10 will improve the mitochondrial function, and then what will happen? They will blow up in a form of mitophagy, because those mitochondria cannot survive. Those healthy mitochondria that you produce by QQ10 cannot survive the tumor microenvironments, and they will blow up and release all those free radicals, and what we call this as a form of mitophagy. They become like little bumps. Or you are causing more damage to the mitochondria, where they release enough free radicals to kill the cancer. And we have a lot of repurposing drugs that we are using, like metformin, and the metformin can cause enough dysfunction in mitochondria to release enough of free radicals to blow up the cancer. So there is two ways of doing it. You can improve the mitochondrial function, making it function and then blow them up, and that's through QQ10, or use metformin and cause the mitochondria to become even more dysfunctional, more leakage to release enough free radicals to destroy the cancer. And this is what we call it, deregulating the cellular energetics. You can consider mitochondria as a little bombs inside the cancer cells that we can take advantage and give them the drugs that either cause the mitochondria to be completely dysfunctioned enough to release enough free radicals that will induce the apoptosis, or you reactivate them and then they will blow up after you reactivate them with QQ10 and NAD and induce apoptosis and mitophagy. So either way would help to destroy the cancer using QQ10 or metformin. The tumor microenvironments, as we see here, there is immune cells in the tumor microenvironment, and most of the time those immune cells are suppressive immune cells in the tumor. And we know why, because the tumor secretes chemicals that cause the suppression or cause the polarization of the immune system away from Th1 and M1. And so cause the polarization of the immune system into becoming mReg, into becoming M17, and they start secreting those interleukin 10 and transforming growth factor and interleukin 6. And all those cytokines, they are suppressing the immune system. They are inhibiting the polarization to Th1, M1, which is very important for cytotoxic T cells to kill those cancers. And so if you see here on the green side, those are the immune cells that we need in order to destroy the cancer. This is the right polarization in order to kill the cancer. So we need Th1, we need M1, we need dendritic cells, which is dendritic cells type 1, and we need all the cytokines that those M1 and Th1 and dendritic cells type 1 produce, which is interleukin 12 and interferon gamma, in order to stimulate the cytotoxic T cells to kill the cancer. But the reality is that in the tumor cells secretes chemicals that leads to polarization of the immune system away from Th1M1. That's mean you will see more of Tregs, you will see more of M2, you will see more of M17 and T17, and they start secreting all those inhibitory suppressive cytokines, which is interleukin 6, interleukin 10, transforming growth factor, and that causes the cancer to grow and flourish, because really we cannot do much in killing the cancer by neutrophils or by immunoglobulin E that Th2 is producing, and histamines. All of this will not help. In fact, it will favor the tumor to grow and flourish And so those are so this is very important to know that when we are managing cancer, it's not enough just to think about destroying the cancer cells using the technique of radiotherapy and chemotherapy, which is basically all leads to generation of free radicals and induce apoptosis and kill the cancer. That's not enough, and that's what we have been doing for a long time in oncology. They are giving chemotherapy, radiotherapy, photodynamic therapy. Even myself, when I was managing my dad, and he has cancer in his hyperpharyngia, I was thinking it's all about just kill that cancer, just generate the free radicals and induce apoptosis, and you get rid from the cancer. And finally, we find out that's not enough. We need to also change the microenvironment in a way it becomes a hostile environment for the cancer, and polarize the immune system into Th1M1, because your cancer is inhibiting Th1 and M1, and it's moving it to Treg, Mreg, and your cancer also is secreting chemicals that leads to fibrosis, and fibrosis squeeze the blood vessels, preventing those lymphocytes from infiltrating the cancer, and you will have cold cancer. In addition to that, your cancer cells is secreting chemicals that will cause the blood vessel to become kinky, and that kinking and twisting and pressure of those blood vessels will not allow those cells, lymphocyte cells, to infiltrate into the cancer, and you end up with cold cancer. So you need to normalize the vasculature of the tumor using Avastin. That's one way, which is antibody that inhibit the VEGF, vascular endothelial growth factor. Also, you need to look at the way that you can break the fibrosis of the stroma. So that would help to decrease the pressure of the blood vessels and allowing those lymphocytes infiltrate the cancer and turn those cancer into hot cancer and active cancer. And then you need to polarize the immune system into Th1 and M1 using all those repurposing drugs we talked about that inhibit the Th17 and M17. An example of that is ivermectin, all those antifungal drugs, most of them, what they do, they inhibit the Th17 and M17. And doing that, even low dose naltrexone, doing that, inhibiting the Th17, M17, or inhibiting Th2, M2 using antihistamine, all of this would help to polarize the immune system. Or using interferon gamma and thymosin alpha, this will help to polarize the immune system into Th1, M1. And as I said last time we talked about cancer, we know that there is immune surveillance of the cancer. There's phases and components of it. And we say there is, the first phase was elimination, where the immune system is getting rid from any cells that turns into cancer. So those cells that turn into cancer, the macrophages will eat them and polarize it to Th1 and destroy those cancer. So you don't see any cancer there. And then, but sometimes as those cancer cells, they can evade the immune system a certain way and they start dividing. You may have something that's called subclinical tumor, where the number of the cells that's been dying by the immune system equal to the number of the cells that's been emerging from the cancer. And that's where we call the equilibrium phase. And then when your cancer starts secreting all those chemicals and able to evade the immune system, then you will have what we call the escape phase. And in the escape phase, where you will see a clinical tumor. And you will see that the immune system is incapable to keep up with the growth of the tumor, because the tumor is suppressing them. The tumor is polarizing them away from M1, Th1, and the tumor is providing that microenvironments that preparing for a microenvironment that is favorable for the tumor to grow, whether by increasing the blood vessels, as I said, kinky blood vessels that allow the cancer to be nourished and fed, and also by stimulating the fibroblasts and fibrosis, which also help to squeeze those blood vessels, preventing the infiltrating T lymphocytes from getting into the cancer cells. And by the tumor itself is being, there's genetics of the apoptosis and the pro-oncogenes that are being mutated, and they don't respond to the external signals that normally that stimulate them and induce apoptosis. They become resistant to cell death, and they are dividing unstopped, and they make the mitochondria to be leaking enough of free radicals that cause the cancer to be dividing nonstop. And so there is many ways to target the cancer using all those tools that we have. And very importantly, if we use those tools, we want those chemotherapy, those polyphenols, those repurposing drugs, those antibodies to reach the cancer and not to get it everywhere in the body. And we mentioned that those tumors, because they are leaky more than the normal tissue, so it's very important is to load those injectable drugs, whether it's chemotherapy or polyphenols or antibodies or repurposing drugs, into nanoparticles, which is the best is going to be platelets from your own membrane of your own body, and get those nanoparticles of platelets loaded with those cocktail of chemicals and antibodies and repurposing drugs into the tumor, because you don't want those antibodies blockade goes everywhere. So those immuno-oncologists, they are giving those antibodies nakedly. The problem is that if you inject them and it goes everywhere, then it will induce autoimmunity, and it will induce a lot of problems in the body, especially autoimmune. Because what you're doing with those antibodies, you are stimulating the cytotoxic T cells, and those cytotoxic T cells, they will kill the cancer, but also they will cause destruction of your own tissue. And that's why people who are taking those antibodies, they end up with severe colitis, which is autoimmune. And if there's any underlying autoimmune diseases, they will trigger that. And so that's the problem that we see with immuno-oncology, is the side effects of those antibodies. But if we can find a way to get those antibodies into the site of the pathology without going much into the normal tissue, I think we can be more successful than the mainstream medicine, who are very excited about this immune oncology field, and we can make it even more effective.
Dr. Halasa, can you explain again, why do they develop autoimmunity when you give the naked antibodies?
Because what you're doing with your antibodies, you are activating and turning the Tregs into Th1 and Mregs into M1. And think about, if you have a Treg that's being developed to prevent autodestruction of your own tissue, or you produce Tregs so you don't eat your own microbiome and make it tolerance. So what will happen, you're taking that cover, you are causing this immune tolerance to your tissue intolerance, and that will develop autoimmunity. So the way that our body, our immune system is not reactive against our own tissue, part of it is that we have enough of Tregs, Mregs that's being developed in our body that is tolerance to your self-antigens. And if you give those antibodies, they indiscriminately will turn those Th1, M1 into, those Treg and M2 and Mreg into Th1 and M1 and cause self-destruction and trigger autoimmunity. So if we're able to get those antibodies into the cancer, and that's where you need to turn the Tregs into T1 and Mregs into M1 and M2 into M1, then that's a good thing. But I don't want to turn those to, their immune tolerance of our self-antigen. It makes sense?
It makes sense, but what you are trying to say that is the response you want in the tumor, but you do not want into the generalized body where the cells are normal. Am I right?
Yeah.
That's what you're saying.
Exactly. And your
Okay.
immune system is being, they have Tregs and Mregs for your self-antigens, and you don't want to turn them into M1 and Th1 where they start destroying your self-antigens. Same like chemotherapy. You don't want chemotherapy to go everywhere. You want it to go into the cancer only as much as you can.
Right,
So
but it doesn't happen in the traditional oncology. Traditional oncology, everything goes everywhere.
yes, that's the problem. So that's where we are going to be better. That's why there's a field that's called nanotechnology, and especially using your own membrane and your own nanoparticles from your own platelets. That is the best way of doing it. And as I said, there's a company who is now producing platelets nanoparticle or moving forward with that, stabilizing it with PSGA. We're not using PSGA because we don't want to have a stable drugs because we're not selling it. So we are doing it in a clinical environment where it's going to be very, friendly, clinically friendly, and it can be done in the clinical setting. So that's why we are promoting nanotech. It's not just for cancer, but also for rheumatological diseases. It's the opposite.
Right, you're right. So,
Right.
so in an autoimmune disease, what you want is that it's a Th17 dominant, right? Autoimmune disease is Th17 and Treg dominant. So you want to push them into Th1.
In no, this is different. No, autoimmune diseases, okay. It is Th17, and some of them are even Th1. So there's no autoimmune disease, they're Th1 and Th17. And you don't want to, if you're treating autoimmune diseases, you want to move them from Th1, Th17 to Treg. But in cancer, you're giving drugs that polarize the immune system into Th1, and doing that itself can trigger the autoimmune disease because Th1 is part of autoimmune disease. You got my point?
Yeah. So I this is, by the way, when we give the thymosin alpha 1, we want the Th17 to come to Th1, and have a less of the autoimmune reaction and control the autoimmune disease. So how does that go
So,
then?
so are you talking about cancer or you're talking about autoimmune disease?
No,
Because
no, I'm talking about autoimmune disease because
okay, and
I think
autoimmune
that we want
diseases, no,
to make sure everybody understands that. That's
no,
the why
no. In
I'm
autoimmune
intervening.
diseases, I don't give thymosin alpha. I don't want to polarize the immune system to Th1 or to Th17. I want to polarize the immune system away from Th1 and Th17 into Treg and T2, Th2. You got my point? Let's say you have rheumatoid arthritis. Rheumatoid arthritis is Th1, Th17 dominant immune disease. In rheumatoid arthritis, we want to polarize the immune system away from Th1, Th17 into Treg, Th2. So it's completely different from cancer.
So what would you what peptide would you give to do that?
For autoimmune diseases, I give thymosin beta and erythropoietin peptides and give them polyphenols, which will help to inhibit the Th17 part. Yes, so that's what I will do for autoimmune diseases.
Right. Now we are talking about the case of cancer.
Now,
And in cancer, we have a Treg dominance, and probably so what
yeah,
would you
and
do
cancer is
then?
different. So I want to move things back into Th1, not even Th17. I want to even more polarize the Th17 into Th1.
Right,
So I
exactly.
want to move everything to Th1. So if I use drugs that inhibit the Th17, that's good. So in cancer and autoimmune disease, I can still use in both sides. I can use drugs that inhibit the Th17, which is okay, which is like low dose naltrexone, works in both sides because Th17 on both sides are not good. You got my point?
No, what does that mean?
In cancer, you don't want Th17 hyperactivity. You don't want interleukin 6. because that will give you neutrophil. Neutrophil will not kill the cancer.
Right. No, we
So
understand
I want
that.
to inhibit that. Also, in autoimmune diseases, you don't want Th17 and neutrophil because that will destroy your tissue as well. So I want to inhibit that. So there is some drugs where it can be used on both sides, which is like low dose naltrexone and polyphenols and low dose. They do inhibit the Th17, which is a good thing. That's what we need on both sides of the equation. You got my point? But in thymosin beta, I will not give thymosin beta for patients with cancer for sure, but I will give it for autoimmune diseases. It makes sense? So in both autoimmune diseases and cancer, Th17 is bad. I need to get rid from it. That's why you can use hydroxychloroquine in cancer and also use hydroxychloroquine in autoimmune disease, because Th17 overactivity is a problem for both sides. Or in cancer, you want to polarize the Th17 to Th1. That's great. But in autoimmune diseases, you don't want that. You want to inhibit as much as Th17 as much as you can. It makes sense? Yeah? Okay. So tumor microenvironment. So again, a tumor is not just, we used to learn, or we know that tumor, it's all about, cancer cells, and our target is just go ahead and destroy the cancer cells. That is not anymore true. It's not just enough to kill cancer cells with chemotherapy, radiotherapy, photodynamic therapy, radiofrequency ablation. Now we are thinking outside the box, and even the mainstream medicine, they're thinking outside the box, and they say we need to change the tumor microenvironment to make it a hostile environment, not a favorable environment for the tumor. And so that is what we are doing with our technology. And what we are adding, CDP MCS, is we adding the nanotechnology part. So we can deliver those repurposing drugs, that's injectable repurposing drugs, those polyphenols, those chemotherapy in a low dose. Even if we can do photodynamic therapy, even if you want to do radiation therapy, it's good to have some chemicals that are sensitive to the radiation, like methylene blue and indocyanine green, nanoparticle, and then you inject them, and then you do radiotherapy, for example. That will lower the dose of the radiotherapy needed to destroy those cancer cells if you add radiosensitive. Or they're using, in mainstream medicine, they're using that concept as well. They use cisplatin and carboplatin because they are active or radiosensitive. So when you use this chemotherapy of cisplatin, and because they absorb the X-rays, they will make the cancer more sensitive to the X-rays, and that helps to kill the cancer. So that's a kind of combination of chemo and radio. We do that with photodynamic therapy as well. We give the photosensitizers, they accumulate the cancer, and then we shine a light, generate free radicals, induce apoptosis. Or you want to do the repurposing drugs of mitochondrial mitophagy, drugs that induce mitochondrial mitophagy, is same as CoQ10 and NAD and metformin, and also keto diet, depriving the patient from sugar. All of this will help to kill the cancer. You can also use antifungal drugs. How the antifungal drugs? Most of antifungal drugs, they inhibit the Th17 and they kill the fungus itself, or they kill the parasite itself. Because that is very important, because people, they say, well, why antifungal? It will help to kill cancer. Those drugs are being designed to interfere with the metabolism of the fungus. That's not true. That's true. That's what they do. They interfere with the synthesis of their membrane of the fungus, and we know that for sure. But in addition to that, the other quality of those antifungal drugs, that they inhibit the Th17 and interleukin-6. That's why ivermectin and hydroxychloroquine, we used it even to treat COVID, because we know COVID and virus is polarizing the immune system to Th17. We need to inhibit it. And if you see the ivermectin, we're using it for rosacea. And why are we using it for rosacea? Ivermectin does kill the mite, right? By opening up those calcium channel and kill the mites. But also you need something to decrease the inflammation. What is the inflammation of the rosacea? You don't want to suppress the whole immune system using steroids. You want to only suppress the immune portion components that is causing the inflammation. So what is the immune components? Is it Th2? Is it Th1? Is it Th17? In rosacea, it's Th17 interleukin 6. So ivermectin is killing the mites, plus it decreases the inflammation. And that's what you need. Even in fungus infection, it's not just the fungus is destroying the tissue, it's also the immune system, overreactive immune system, which is Th17 and the neutrophils, is destroying the tissue. So what you want to kill the fungus and you want to suppress the Th17, overreactive inflammation of the body, because that is part of it. If it's overreactive, is causing destruction of your tissue. So you need to minimize that. Now, we don't want to minimize it too much because neutrophil is the way to kill the fungus, but we're minimizing it so that we are getting rid from the unneeded overreactive inflammation, which is causing more of tissue destruction. So that's why we're giving those antifungal to kill the fungus and also decrease the inflammation. So again, back to the tumor. So the tumor is not just anymore just cancer cells, but also it's the tumor microenvironment, which is the fibroblast that is producing fibrosis, and fibrosis is enhancing the growth of the tumor. It's squeezing up the blood vessels, preventing those T lymphocytes infiltrates. Platelets can also wrap around the cancer and form a shield around them against your lymphocytes. So you need to give some antiplatelets, and that's why we give aspirin for a patient with cancer. The blood vessels, those endothelial cells, they get kinked, in other words, and they start overgrowth, but kinked, which allow the sugar to go in and nutrition to go in, but it will be squeezed or kinked because those blood vessels are abnormally twisted and tortuous. So the easy can be kinked, especially with a fibrosis, and this will not allow the big cells to go in, especially the macrophages and the lymphocytes. And so we need to restore that by blocking the VEGF, the vascular endothelial growth factors, using Avastin. So those are very, very important in managing cancer. So it's not enough to kill the cancer by radio and chemo. It's also, you need to work on the fibrosis, the platelets. You need to work on restoring the vasculature of the blood vessels. Plus, you need to work on polarizing the immune system from Tregs, because there will be a lot of Tregs and Mregs and myeloid derived suppressor cells. All of this, we need to polarize them into Th1, M1, and cytotoxic T cells in order to kill the cancer. And the cancer is secreting chemicals and is expressing on their surface receptors that will turn off those immune system and polarize them away from Th1, M1, and that needs to be reversed when you are managing cancer. If you see here, this is the prostatic cancer, and this is I think a stained slide of prostate cancer, and you will see that here in the center, this is the necrosis, this is the cancer itself, and this is the stroma. Okay, and when I'm going to manage cancer, I'm giving chemo and radio, we're destroying this part, right, the cancer, and we are not looking at the stroma. And that's something that we need to change that mindset, because the stroma can suppress the immune system. So this stroma contains fibrosis. The fibrosis will squeeze those blood vessels, preventing those T lymphocytes and macrophages from going in. And in this stroma, also, they are very rich with macrophages and Tregs, which will suppress the immune system to destroy the cancer. So the immune system, if it's being polarized into Treg and Mreg and M17 and T17 and myeloid-derived suppressor cells, which is naive macrophages, all of them, they start secreting chemicals that will inhibit the cytotoxic T cells from developing. It will have the Th1, it will have the M1s, and then those immune systems, they actually causing protection to the cancer, allowing the cancer to grow even more and more. So it is very important, in addition to target those cancer cells, using chemo and radio and photodynamic therapy and radiofrequency ablation, name it, to induce apoptosis by increasing their free radicals or interfering with their metabolism. So you have drugs that interfere with the cancer metabolism or generate free radicals. And some of those drugs that interfere with the metabolism, they also increase the free radicals ultimately and induce mitophagy and apoptosis. In addition to that, you need to also consider to change the tumor microenvironment so it will be a hostile environment in a state of favorable environment for the cancer. We see here some slides just to show you that it's not just tumor cells, it's also the tumor microenvironment. And if you see this slide here, you see the macrophages, which is red color, and then the tumor cells, which is the green color, and then the blue are the stroma here. Okay, but you see that those macrophages, most of them, they are mregs and or white blood cells that are Tregs. So they are helping the tumor to grow, and they are suppressing the immune system, preventing the cytotoxic T cells from developing and killing those cancer. And yes, if you see that the tumor is very rich with white blood cells, we call them hot tumor, but it does not mean that those are white blood cells or those lymphocytes are eating the tumor. Those could be, those white cells could be Tregs and mregs, and actually they are stimulating the tumor to grow even more and more. And if there's inflammation, as I said, those are wrong inflammation. That's not inflammation that destroys the cancer. Those are inflammation of neutrophils, of mast cells, of the Th2 mediated and Th17 mediated. Those inflammation are not killing the cancer. In fact, they are helping the cancer to grow by increasing the growth of the blood vessels, and those inflammation causing destruction also of the surrounding normal tissue, allowing this cancer to grow even more and more. If you see here another slide, in macrophages is the green, and then the red is the stroma here. And if you see the macrophages is in the border of the blood vessels of the stroma, and if they are, think about it, they are mregs and Tregs, then any white blood cells goes in, let's say a Th1 goes in, and the Th1 faces an M1, faces an mreg. The mreg can inhibit those T cells, the Th1, and turn them into Tregs. Or you have a Tregs in here, and you have a macrophages M1 going there trying to kill the cancer. Well, the Tregs will combine with the macrophages and turn them off, and turn them from those T cells will turn those M1 into mregs. So this is very important to understand that it's very critical to polarize the immune system away from Th1 and M1, because those mregs and those Tregs, they can suppress your immune system. Even if you give them cytotoxic T cells or you give them Th1 and they're trying to get into the tumor, well, if you have mregs and Tregs, they can turn those effector Th1 into Tregs, and they can turn the M1 into mregs. So it's very important that we need to turn those macrophages and polarize them into M1 Th1, because they are suppressing, and you have this vicious circle of suppressing the immune system, preventing the cytotoxic from evolving and killing those cancer. The same here also, we have another slide as you see it here, and in this slide, which I'm trying to see it here, okay, it's the same thing. You will see that there is the red and the green. The green is the tumor, is the macrophages, and the red is the stroma here, and then the black one here, this is the tumor cells. And if you see here, those macrophages, if they are mregs and Tregs on the border of the tumor and the blood vessels, so any Th1 goes in or M1 goes in, those mregs will turn them into from M1 turn them into mreg, and from Th1 will turn them into Tregs, and they go suppressing any incoming lymphocytes that's going to kill the cancer, and turn them off. And that's the problem that we have in cancer. And knowing that, knowing your enemy, knowing how your enemy works, then you can have better strategy and making tools to reverse that and to fight better. So even when we have a battle with an enemy, we have spies, and the spies will read the enemy tactics, and understanding the pathophysiology and the mechanism of the cancer, it's very critical. So we understand how we can manage the cancer, because the way that we are doing it before, shooting in the dark and giving the same chemotherapy for everybody and focusing only on destroying the cancer cells, that's an old school. And that's the reason why we're not successful in managing cancer, and the death rate of cancer is still very high. I'm talking about very, very high. Almost 70% of people diagnosed with cancer, they die. We did some improvement with immune therapy, but still there is a problem with immune therapy, is the targeting those immune therapies into the cancer. That's where the mainstream medicine is still behind. Now, they are working on turning all the chemotherapy into nano, but the nano they're doing is synthetic phospholipids, like doxorubicin, they turn into Doxil. But the phospholipids of the Doxil, it's synthetic. And the problem with that is that the macrophages in the liver, they look at those nanoparticles, those phospholipids, as foreign, and they take them. So if you have a tumor in the brain and you inject Doxil, and you say, well, you know, those Doxil are nano-sized, so that's mean they will favor the area of the leakage of the tissue, which is the cancer, versus the tight junctions of the normal tissue. So you think, oh, all this Doxil will go into the brain tumor. That's not the case, because the liver has macrophages. They will look at those foreign nanoparticles, those phospholipids are synthetic, and they will take them. The lungs also have macrophages. They will take them, and that hinder those drugs from reaching into the brain tumor. And that's the reason why we switch and say, oh, it's better if we use our own phospholipids from our own tissue, which is the platelets membrane or red blood cells membrane, and wrap them. It's like a torsion, and we can hijack that, preventing those macrophages in the liver and in the lung to take them. And that goes more concentration of those drugs, those platelets nanoparticles, those loaded with drugs, or loaded with antibodies, or loaded with repurposing drugs into the cancer tissue. Okay, so this is what we just talked about. We said if the tumor has high level of MREGs, has high level of myeloid suppressor derived suppressor cells, which is those naive macrophages, and they have a high level of Tregs, right? Then what will happen here? They will be secreting all those interleukin-10, transforming growth factors, and even if you have tumor that's high level of Th17 and you have too much of interleukin-6, all of this will polarize the immune system away from Th1M1. So you don't have much of Th1M1, you don't have much of cytotoxic T cells, and you cannot kill the cancer, right? So you see here, there's less of M1s here, all right? But what we need to do is to inhibit the MREGs, inhibit the Tregs, inhibit the Th17 as much as we can, and make the immune system to be polarized into M1 and Treg and dendritic cells type 1. And that's what we did see here. And so the tumor that we are able to polarize the immune system to Th1M1 and produce enough of cytotoxic T cells, yeah, then we can definitely kill the cancer more effectively. So this is very important in managing cancer, is polarizing the immune system to Th1M1 as much as you can by inhibiting all other polarizations, inhibiting the Th2, inhibiting the Th17, and inhibiting Tregs, and moving the immune system more into Th1. Now, again, I like thymosin alpha, but thymosin alpha, according to Mike Beamer today, he's telling me that it's just hard to compound it because, again, it's regulatory, although some compounding pharmacies are doing it. So, you know, and Mike Beamer is a pharmacist who's very intelligent, was looking for both, you know, win-win. He does not want to butt head with regulatories, and he wants to create an alternative. So is there anything that we can do in the United States that will polarize the immune system to Th1, and we can compound and use it. Yeah, you can use polyphenols. You can use spirulina. You can use you can use interferon gamma. Interferon gamma is an FDA-approved drugs, and it can be replacement for thymosin alpha. So if you cannot get the thymosin alpha, then think about tumor of interferon gamma. Now, one of the problem with interferon gamma, yes, it will polarize the immune system to Th1M1, but it stimulates the tumor cells to express PD-1, and PD-1 will turn off the cytotoxic T cells by reacting with PD-L1. And that's the reason when you give interferon gamma, you need to give antibodies that blocks the PD-L1 together. So you give interferon gamma and you give the antibodies to block the PD-L1, you can get better results than just giving interferon gamma in terms of cancer, when you're managing cancer here. And that's why for COVID, you know, giving a little dose of interferon gamma may help to polarize the immune system to balancing back to Th1 and have the Th17. Something you want to do also for post-COVID-19. Again, so let's go back to phosphatidylserine.
Dr. Lassa, really quick, quick question. So my understanding is we want to convert M2 to M1. We want the M2 as anti-inflammatory macrophages, and then M1 is inflammatory macrophages. Is that correct?
Right. So in this case, this is very important to know that if you have excessive amount of M2, they are actually can produce inflammation. Your allergy, it's inflammation mediated by M2 and Th2. So too much of it is inflammatory. Too much of Th17 is inflammatory. So we want to switch that kind of inflammation mediated by M2, and which leads to histamine and bradykinins. We want to switch them into the right inflammation that kills the cancer. So in the tumor, there is inflammation, but wrong type of inflammation. There is inflammation of neutrophilia, which is mediated by Th17. There's inflammation of histamine-mediated M2. You want to move that back into Th1M1, the right inflammation that produces the cytotoxic T cells to kill the cancer. You got my point? So,
yeah, that's a great distinction,
right.
because you know, my understanding was that you know, M2 was anti-inflammatory.
So let me explain to you. Yes, it is anti-inflammatory, though.
But I understand. But you're saying it's like too much of it is
inflammation. Yes. So let's say when I move things, let's say you have in autoimmune diseases, you have too much of Th1 and Th17. So that's inflammation. That kind of inflammation that produces cytotoxic T cells. That's inflammation. If you switch them to M2, this is an anti-inflammatory effect because you're taking away from the inflammation that destroyed the tissue into M2 and moving it, you're decreasing the inflammation here. So it has an anti-inflammatory effect, and you're not switching it to too much of M2 where you produce another inflammation. You're producing it enough to balance the immune system, and the total effect is going to be anti-inflammatory. You got my point?
Yeah, no, that's a great analogy. That's very clear.
All right, great. So let's go and learn about something new here. This is very, very important part and the missing part that we have in managing cancer. And it's still under clinical trials, but I think the FDA approved this antibody blockade that blocks the phosphatidylserine. And we're going to talk about how that phosphatidylserine is important to be blocked in managing cancer. We will see that normal cells, they don't have phosphatidylserine on their outer layer of their membrane, but you know, the membrane of the normal cells, it's made from two phospholipid layer, right? The outer layer, they don't have phosphatidylserine. phosphatidylserine serine, it's only in the inner layer of this lipid bilayer. There's two layers. The outer layer, there is no phosphatidylserine, but it's very rich in the inside. The inside layer of the membrane is very rich with phosphatidylserine. Okay, but we will see that when those normal cells turn into tumor, what will happen, those phosphatidylserine in the inner layer of the membrane will flip and move to the outer surface, will flip to the outer layer. And this causes the tumor cells to be marked with phosphatidylserine as an outer layer. And that will cause attraction to the macrophage to eat them. But at the same time, it will suppress the immune system and polarize the immune system to M2, MREG. And that's what we're going to study here. And that's the problem with phosphatidylserine. Now, in normal cells, we see that all the phosphatidylserine, it's in the inner layer of the membrane, not in the outer layer. But when the normal cells are going to die because of the aging and because of the free radicals and all that stuff, those free radicals of the aging will cause and activate enzymes or that will flip the phosphatidylserine from inside to outside. And once it's getting into outside, then your immune system will recognize it and start eating them. So it's an eating signal. And you want to eat them without, normally, you want to eat those aged cells without causing too much of inflammation. And doing that, the immune system, your macrophages will turn into M2. They will eat those aged cells, but in a form of M2 and MREG, which means that they will not induce the cytotoxic T cell, which is good. That's what we need, because I don't want inflammation, too much inflammation, when I will induce autoimmunity. If those macrophages that eat the aging cells, they turn into M1 and they stimulate cytotoxic T cells, that's a problem. Then you will be inducing autoimmune that cause destruction of your own tissue. It's like exactly, and this is a doctor who also was, doing the research here, and I like what he said. It's like the garbage truck in the morning. You want to collect the garbage without causing any noises to disturb the neighborhood. So you want to eat those aged cells, those cells that their phosphatidylserine is being flipped to the outside as a signal for eating me, without causing noises to wake up the neighborhood, without stimulating the M1 and cytotoxic T cells. You just want to eat them and that's it, and take them out. And the tumor is taking advantage over that. And the tumor cells also, they do the same thing. They flip their phosphatidylserine from outside, but then the macrophage will eat them. But those macrophages, they stay, or they polarize into M2, MREG. And that is a problem, because then you are suppressing the whole immune system. And that's one of the mechanisms of invasion of the tumor to the immune system. And that's why if we block that phosphatidylserine, then those macrophages, when they eat those tumor that's being blocked by phosphatidylserine, they will polarize into M1 and Th1 eventually, and will simulate the polarization of Th1, and that helps to destroy the tumor. So that's what we're gonna see here in the coming slide. So this is as I talked about, normal cells, the phosphatidylserine are inside. Normal cells, as long as the phosphatidylserine is inside, the macrophage will consider them as self-antigen or self-tumor, self cells, self and normal cells. So they will not attack them. But once they flip, in those normal cells, let's say, for example, they get aged and old, and they start producing too much of free radicals, the mechanism of aging, then this will stimulate the flip of the phosphatidylserine from the inner layer to outer layer and being exposed. And that's a signal for those aged cells to be eaten by the macrophage. It's like eating me signal. And the macrophage will go and eat them. But when they eat them, they don't turn into M1. They turn into MREG and M2. And that's a problem if those cells are tumor cells, because it's good for aging cells because you don't want to induce autoimmunity and disturb the whole other cells and induce cytotoxic T cells and M1, which will then you'll be killing and destroying even the normal cells, not the aging cells, the neighborhood, right? You don't want that. And so you want it to be staying in a form of MREGs. Just eat that and that's it. And keep it quiet. But in tumor cells, we need to turn them into M1 to kill the tumor and the surrounding tumor as well. And we don't want those macrophages to stay in a form of MREGs and M2, because then what would happen is that this will suppress the immune system and the tumor start growing and invading the immune system, right? And you have this escape phase coming up. And you don't want that. And so that is the reason we can come up with antibodies blockade to block the fusdieserine. And doing that, when you block the fusdieserine, then the macrophages, as we remember when I told about the macrophages, when they eat the tumor, they polarize naturally into M1. But with this fusdieserine on the surface, it can make those tumor cells to polarize into MREGs and M2, and that's what you don't want. And so from here, we understand the tumor is hijacking this mechanism that we wanted to get rid from the aging cells, and they're using it in their advantage to evade the immune system. And so this is how the PCS signal, the PS signaling, which is the fusdieserine signaling. See, there's the macrophages. When they eat those naive macrophages, which is the myeloid derived suppressor cells, those are naive macrophages. And then those naive macrophages, when they eat those tumor cells, they end up polarizing into M2 and MREG, and that's what we don't want. All right, we want them to be polarizing to M1. So what we will do, if we have antibodies that will block the fusdieserine, then there will be no more signal of PS signaling in that tumor, that macrophages. Then what will happen to those macrophages? They will polarize into those naive macrophages. They will polarize into M1, and they will secrete those interferon gamma, interleukin 12, and polarize the TH naive into TH1, and the TH1 starts secreting all those chemicals that will stimulate and activate the CD8 cytotoxic T cells and kill the cancer. So this is the case of what's happening of the tumor to evade the immune system by the PS signaling that needs to be inhibited, right? Because then you would have the tumors very rich with those naive macrophages and those MREGs, and also they can also polarize, as I said, if they start producing interleukin 6, then they polarize into M17 and TH17 and neutrophil and M2 and interleukin 4, which this will definitely favor the tumor growth, because all the cytokines from the other side, they are inhibiting the M1 and TH1 polarization.
Dr. Halassa, real quick, as a question, what are the implications of blocking this phosphatidylserine with an antibody? If this is an immune signaling molecule, what would be the implications of blocking it on the rest of the body?
Yes, so that's one of the problems with all this antibody blockades, not just for PS, even for CTLA4 antibodies, PD-L1 antibodies. This is the problem with immuno-oncology, that those antibodies, they will help to kill the cancer, but they will trigger autoimmune diseases, and they will cause a lot of collides. And doing that is not good, because then you're debilitating and exhaust the immune system in general. If you start activating your immune system all over, then that's not good for the tumor as well. So that's the drawback of the immune therapy. Now, how we can turn it into our advantage is to load those antibodies into platelets nanoparticle and getting those antibodies into the tumor and not to the everywhere. And that's what Dr. Patel is doing. Hopefully Dr. Carterfield is doing, and my people, CDP MCS, when they learn the platelets nanoparticle technique, then they can do better than the mainstream John Hopkins and Mayo clinics who are injecting those antibodies nakedly. And yes, they will kill the cancer, that's true, but at the same time, they will trigger autoimmune diseases. And if you trigger autoimmune diseases, you also going to suppress the immune system because your immune system will be overactive everywhere and it's not focused. And you exhaust the immune system doing that. And that's why you have only limited number of courses that you can do because of that. Chemotherapy, the same thing. You have limited courses you can do. Reason because if you do more than that limited courses, it will suppress, it will cause destructions of all your tissues and suppress the immune system and cause the tumor to flourish. That's why you have regimen for the chemotherapy. You cannot go beyond it. If you go beyond it, then you're suppressing the immune system, then you're causing the tumor to flourish. And that's where the whole cancer regimens are limited to certain weeks and months and certain courses and regimen. And you cannot do more. That's why when you do them, they will say, okay, you did the chemotherapy, you're not qualified to do chemotherapy again maybe after 1 year or 6 months. We may try it again, but most of the time they end up, those mainstream medicine, they say, you know what, we did all the chemotherapy, we did all the radiotherapy, we have nothing to do for you. So they send you to the hospice and you die there. That's where we're trying to tell them there is an answer for that. Instead of giving them high dose chemotherapy, why we don't give them low dose, load them in nanotop particles where you can do more. So the regimen will be different. When you do low dose chemotherapy in nano, then you can do even more because you're getting those drugs into the cancer. You're not getting it everywhere and you're not suppressing the immune system. You're focusing more into the tumor. So this will help. Low dose chemotherapy with nano and low dose antibodies loaded with nano. I think it's the future of cancer management, and that will help to improve all the side effects that's being generated by chemotherapy and immunotherapy. Does that make sense? Dr. Mike, are you there? Okay. Can you hear me,
makes
guys?
sense.
Okay, great.
Yeah,
great.
that makes perfect sense.
Yeah, no, I definitely agree. I'm listening. Absolutely. No, it's a complex subject. No, I totally agree with what you just said.
Right. So
It's about
basically,
the balance of it. You can't, you're having to drive between the lines, not too far to the left and not too far to the right.
exactly. Now, the good thing about this antibody is now when they block the PS, which is the phosphatidylserine serine on the surface of the tumor, then the antibodies has the other side, right? It's like a fork. And so you have the one side is attaching the tumor, the other side will be attaching, for example, to the receptor in those macrophages called the FC gamma receptor. And once that's been activated, those macrophages will turn into M1. And then when those macrophages turn into M1, what would happen? They start secreting interleukin 12 and interferon gamma, which will cause the naive T cells to turn into Th1, and then the Th1 along with the M1, along with the naive CD8 cells will turn into what? Into cytotoxic T cells, and the cytotoxic T cells will go ahead and attack those cancer. Right. So there is some antibodies mediated killing the cancer as well. So we antibodies are not all the way bad. We still use some antibodies to kill the cancer, but we need more of cytotoxic T cells. And very important. Otherwise, if everything is being shifted to Th2 and you have antibodies is not enough to kill the cancer. You need to have balanced amount of antibodies and cytotoxic T cells in order to eradicate the cancer. Okay. So the phosphatidylserine is a global immune cell. It's a global immune cell suppression, or it's a global immune cell signaling that suppressed the immune system, and it suppressed the dendritic cell function. Yes, it prevent the dendritic cells from becoming dendritic cells type 1. They become dendritic cells type 2, which is or dendritic cells regs, which actually will suppress the immune system to attack the cancer. And those PS1, they will also polarize the macrophages, as I said, toward the M2 and M regs. And if the tumor cells are degrading interleukin-6, then they can polarize them into M17, and then you have also Th17 there. It induces the production of immune suppressive cytokines. Yes, when they become mReg, then they will be producing tumor necrotic, the transforming growth factor beta, interleukin-10. And if the tumor cells start secreting interleukin-6, and we know how the tumor cells produce interleukin-6, one of the way, because of the mutation of their genes, those tumor cells express a lot of angiotensin to type 1 receptor. Do you remember the angiotensin 2 type 1 receptor we talked about in COVID-19? Well, the tumor cells express a lot of angiotensin 2 type 1 receptor. And angiotensin 2 type 1 receptors, when they're being activated, they will signal the expression of interleukin-6. And you have a lot of interleukin-6. And interleukin-6 is not good for cancer because it will stimulate the fibrosis, it stimulates the growth of the blood vessels, and it will definitely suppress the immune system to kill the cancer because it will polarize the immune system into Th17 away from Th1. And inhibits the production of immune stimulator cytokines such as interleukin-12 and transform tumor necrotic factor that's coming out from M1 Th1. And that leads to what? It promotes T tolerance, right? Is that what's happening to those cancer cells? Their immune system are protecting the tumor in the state of killing the tumor. So, and this leads to, it makes the tumor as they are self-antigen, right? And they are suppressing any destruction of those tumor cells. They will turn those tumor cells to become self-antigen, and your immune system will not be destroying it and protecting them, and they start growing and taking over the body. So we don't want that. We want to turn the immune system to recognize your self-antigen and tolerate it, but we don't want your immune system to tolerate cancer. Okay. Okay, so again, when we are trying to target cancer, we remember those triad we talked about, right? We need to talk about the metabolics, which include the genetics, epigenetics, as much as you can, inhibit all the pathways of the cancer by using chemotherapy, by using all this repurposing drugs that will, part of it will induce the mitophagy, mitochondrial mitophagy. And so you start developing drugs that will inhibit the metabolism of the tumor chemically. So we have that already, right? We have drugs that inhibit the telomeres. We have drugs that will induce mitophagy, and we have drugs that inhibit, for example, the action of the aerobic glycolysis, like metformins. And we have the drugs, which is the PARP inhibitors as well. All of this, we have drugs that inhibit the VEGF, which is Avastin. But also, in addition to metabolics or metabolic drugs that will inhibit the metabolism of the tumor metabolism versus the normal tissue. So you want to look at what is the metabolism of the tumor and find the pathways that is unique for the tumor, that is overactive in the tumor versus the normal tissue, and target those ones and inhibit them. And there's some metabolism where both, you see the normal tissue and cancer, but the cancer is using those pathways too much. Then yes, then you can go ahead with that drugs that target there. It may affect the normal tissue, but if you're able to deliver the drugs into the cancer, you may minimize those side effects of those drugs from affecting your normal cells. And we did very good at that. We have a lot of drugs that's being developed, and we call them chemotherapy for that purpose. So those repurposing drugs that we are talked about, whether it is the antifungal drugs, whether there is the metformin or ivermectin or hydroxychloroquine or low dose naltrexone, or the regular chemotherapy, those cisplatin and carboplatin. And in addition to inhibiting the pathways of the metabolism, Some of those drugs, they do both. They inhibit the pathway and they increase the free radicals, and that will lead to an induction of the apoptosis. When you have those pathways of metabolism, eventually it will lead to increase the free radicals, and then the free radicals will induce apoptosis. So this is what we have been done for many years when we are managing cancer: metabolic and redox. And redox also, photodynamic therapy is under the umbrella of redox. Therapy, chemotherapy, most of them are under umbrella of redox. Radiotherapy, all of this are under redox, right? Because that's what the radiation does. It increases the free radical and induces apoptosis of cancer. Well, we have a little advance before about changing the tumor microenvironments and polarizing the immune system to Th1/M1. This is the new field of medicine. And breaking down the fibrosis using shock waves and losartan, anything that helps the fibrosis of the tumor, it's good. Anything that helps the platelets of the tumor, that's also good. Anything that helps the Th2, like antihistamine, that's what you need. Anything that have the Th17, like ivermectin and hydroxychloroquine and all those antifungal drugs. But what we need to focus on is those antibody blockades that would help to also polarize the immune system to Th1/M1. And we have many of them, like anti-CTLA4 and and PD-L1 antibodies. They're very good in polarizing the immune system and activating the cytotoxic T cells. But also we have this up signaling, which is inhibiting the PS. It's a more global, much more in the upstream, more in the because this will even the PS1, if it's being activated, it increases the expression of the PD-L1, PD-1, and the CTL. So that's very important to know. It's an upstream of the immune suppression, the PS signaling, as you see it here. And activating the PS signaling, it's also increasing the expression of the CTL4 receptors on the T cells, and they become Tregs. And also they will increase the expression in the tumor of PD-1. And that will inhibit the cytotoxic T cells in PD-1. And then those T cells, if they have the CTL4 on them, they become Tregs, and they will inhibit and turn the M1 into NREGs. And so developing antibodies that will block the PD-1, that will block the PD-L1, that will block the CTL4 would help to polarize the immune system into M1, Th1, in addition to inhibition of the PS signaling. Now, we can see here that combined therapy is the best way to go. And monotherapy is not, in cancer, because if you see the cancer, there's many pathways and many ways that we can kill the cancer. And it's not enough just to go one way. It's not enough just to block or induce apoptosis. It's not enough to block the oncogenes. It's not enough to block the telomeres. It's not enough to just block the PD-L1 or CTLA or PS. It's not enough to generate free radicals for chemotherapy, radiotherapy. It's not enough, because you need to do all of them. You need to give them something that helps the fibrosis, something that helps the platelets, something that polarizes the immune system to Th1/M1, something that will increase the free radicals and induce apoptosis, something will induce mitophagy, either by increasing its dysfunction, so they become more leaky of free radicals, like metformin, or activate them, like Cucutan, and then they become like a bulb. They will blow up and they release those free radicals and the calcium and the cytochrome oxidase and induce apoptosis. So those are, we call them the mitophagy inducing drugs. So it's not enough to just use one way. It's not enough just to give chemotherapy and radiotherapy. You have to combine it with all those things that we learned, all these cocktails, and And also you need to study the genetics of those cancers and find out what is the drug they are sensitive to. Because if they are not expressing the PD-L1 or PD-1, really antibodies of PD-L1 will not be effective. And it's a waste of time and money. So the cancer management, it become a turn from the mainstream, which is a cocktail of drugs, use it for everybody, copycat, using it for everybody, into more personalized it, where you study the genetics of the cancer and find out which is more susceptible for this cancer, which is the drugs that is more sensitive to those cancer, which is the pathways that is more active into those cancer, where you can go ahead and block them with the polyphenols, or you're repurposing drugs that you're using, or with Avastin, or with losartan, or with your aspirin, or with all those drugs that we use, or with this chemotherapy, which drug that's sensitive. And there is some lab, they're already doing that. And so monotherapy is not the right answer. Also, just giving them chemotherapy that's good for this patient, using the same one for another patient, is not good anymore. We have to turn the cancer management into personalized, integrative immuno-oncology. That's the future of cancer management. It has to be integrative, not going to the oncologist and, okay, have a course of radiotherapy, here's a course of chemotherapy, and you're done. That's not the right approach anymore for managing cancer. And this is a good example to show that how combination therapy is way more effective than monotherapy. Let's say if we have a rat and you implant a cancer in the lung of the rat, and you have a control and you have the cases, right? So both the control and the cases, they have implanted tumor. And then you give them, let's say, radiotherapy, right? So you give radiotherapy and you see the response there. And you give mice's only antibodies of the PS, which is PS antibodies, right? Antibody blockades. And then you give in another group of rats both serine blockade antibodies and radiation. And what you will see here, let's say in the control, where you just give any antibodies, it's a placebo, right? Placebo. And then you will see here that the cancer is still there, right? Because the light is coming out from the cancer. And if you do just radiation here, it's better than the placebo. And if you do radiation and you do antibodies that blocks the PS, see the red one here, you can get way better effect. It makes sense? So a combination therapies is more effective in managing cancer. So if you use radiotherapy, in addition to using antibody blockades, which is the PS antibody blockade, you can get a better survival rate, and you can get better results. And you can see here the tumor is being eliminated in 11 weeks or 7 weeks using the combination therapy of radiotherapy and the antibody blockade. The same thing here. This is the it just shows you that the control here, right? And using a radiotherapy, which is the red one, and using the antibody, the blue one, and then using the radiotherapy along with using the antibody blockade, see how much the survival rate is, and better results here. Almost 100% survival when you combine therapies together, radiotherapy and the same thing here. If we have the control and then we have the cases here, and we see that in the cancer of the control, what you will see they are very rich with M2 and M-regs as being stained here in this in those cases, right? The one that the control ones, the one that you don't give them the therapies. Okay, and so those tumors, they're very rich with M2 and MREG, which is being stained here. And you will see less and little of M1s, which is very critical and important to kill the cancer. While when you give them the treatment of the PS antibodies, what would happen to the M2? Decreased, right? What would happen to the M1? Increased, and that's what you need. This means the antibodies is indeed polarizing the immune system from M2 to M1 or MREG to M1. As you see here, the sample or the biopsy and histopathology of those cancer of coming from the control and coming from the cases that's being treated with the drug. And also here that shows again those macrophages, and they shows you that how those are the yellow one as you see it here. Those are the macrophages, the MREGs and the M2, and completely in the cases they are not there anymore because they become what M1 and that is decrease the number of the immune suppressor macrophages. And you can also study that in flow cytometry, and you can find out that those macrophages of the tissues of the cancer of the control, they are mostly M2, but if you look at and try to see it in the cases that's being treated with PS antibodies, you will not see any more of those M2 MREG macrophages in the flow cytometer or in the staining because they polarize into M1 and they are destroying the cancer as we see it here. Again, this is just shows you the combination therapy works very well when you combine therapies together. And you see here that the red one here is where we combine the two methods that say, for example, you use the PS blockade and the radiation, or you use any other drugs. Combining it together, you can get even better results, and especially with adding PS antibody blockades, you are polarizing your immune system into M1 and Th1. And if I take the blood from those mice that's being treated with PS antibodies, and I take their site and extract those T lymphocytes there, and I take it and I introduce it to the tumor tissue in vitro, we will see that they are very effective in destroying those tumor cells, even in vitro. So if you take the blood from those rats that you introduced to them or you gave them PS antibodies, and because they polarize the immune system to M1 and Th1, if you take their white blood cells and you from the blood and you mix it with the tumor cells, you will see the tumor cells is being killed by and destroyed by those cytotoxic T cells from those blood of those mice that's being treated with PS antibodies blockade. Versus if you take a rat that is not being treated by PS and you take their blood and you take their cytotoxic T cells and you mix it with the tumor cells, they will not see any destruction. And that's the difference between here and here, the study that shows that how the cytotoxic T cells are being formed, and that gives them some sort of immune. Again, even if you try to reimplant those mice that's being treated with PS with the tumor, they will destroy the tumor because they have active cytotoxic T cells that destroy the tumor. So they have memories that will ensure that those mice that they will not even get the recurrency. So most of the problem we have in tumor is those tumor, you may induce remission with your chemotherapy, but then they will come up again and they emerge. So, or you have recurrency. So by this technology, you are enhancing the immune system, and you're creating a memories of cytotoxic T cells that will kill any cancer that's coming out or emerge as a recurrence. And I think that's what we are looking for. So even those people who are being on remission, I think it's better if we treat them with the course of those antibodies, possibly to create a cytotoxic T cell memories against those tumors. So this will prevent recurrence of the tumor. And that's the advancement that we have in immune therapy. That's why immune therapy it's better to do immunotherapy with your chemotherapy and not radiotherapy, and not just treating the patient with radiotherapy and chemotherapy. Because if you eliminate the cancer using radiotherapy and immunotherapy, and you don't have robust immune system and immune memories, then what would happen to those patients? They may develop recurrence, and they will have recurrent tumor, and because the immune system is unable to eliminate them. But using the combination, I think it's a good thing, enhancing the immune system. And this will also lower the dose of the chemotherapy and radiotherapy that you need if you combine the immune therapy with chemo and radio. Another example is a mice with they're engineered mice with prostatic cancer. And then one of the way we treat prostatic cancer is by castration, orchidectomy. So we decrease the androgens. So if you take those mice, we have control, and then we have another group cases of mice where we do only castration, and then we have another group of mice with the tumor of the prostate, and we do castration and orchidectomy to remove the androgens, and plus the PS antibodies. We will see the results of combining PS antibodies blockade with castration is way more effective than just castration by itself or just antibody by itself, and versus the control where you don't give anything. The survival rate is high, and see almost 50, let's say around 30% or 40% survival rate here of those rats or mice using those therapies. So I think we have a clear understanding that we need to change the tumor microenvironment from being a favorable tumor microenvironment to the tumor into a hostile microenvironment to the tumor, and using this antibody blockades, whether it is CTLA-4 or PD-L1 or PS antibodies, is a good way to do. I mean, it's the future of the immuno-oncology, it's the future of managing cancer, and that we need to adapt that in all our cancer management. But again, the drawback is triggering autoimmune diseases by giving those antibodies nakedly and goes everywhere. And that's why we using nanotechnology may help to target those antibodies into the cancer and minimize the side effects. And yes, it is the future of medicine. I wish this is something that I have been used with my patients and with my dad as well, when I was managing him with his hypopharyngeal cancer. At that time, I was unaware about this technology because it's very new, and they are just recently being approved by the FDA. So what about combining the upstream antibody blockade, checkpoint blockades, with the downstream ones? We talked about the upstream, which is the PS antibodies, which is the global blockade, with the PD-L1, which is the downstream, because as I said, the PS, when they're being activated, they increase expression of CTL4 and PD-1 and PDL on the cells. So that's why it's an upstream. So if you can combine it together, we may get better results. So if you combine PS antibodies with PDL1 or PD1 antibodies or CTL4, I think we can get better results. Here's the melanoma of mice, and we see the cases here where they use only PDL1 or PD1 antibodies versus doing PD1 antibodies and PS antibodies blockade. And you can see the tumor shrinking. It's way more better when you combine both blockades, as you see it here in those red dots here, and there you see the tumor volume here, how it here is more shrinking than the one with only PD-1. And also here, see those are PD-1s, the blue ones, and the red ones, it shows the combination, which is way more effective in shrinking the tumor. Same thing we can do with CTLA for antibodies, and with the PS antibodies. If we combine it, see the yellow one here, you can get better treatment and more shrinking of the tumor and decreasing their size. So I think we understood that from this lecture that phosphatidylserine is externalizing the tumor as a signal of eat me, but the tumor is taking advantage and hijacking that, and the macrophages that is eating those tumor, they are being polarized to M2 and Mregs, which is something that we don't need. It's good for getting rid from the aged cells. Yes, that's great. So you can get rid from them without causing damaging to the surrounding normal cells. But in here, in this tumor where they're hijacking this this method and using it in their behalf, then those macrophages, if they're being polarized to M2 Mreg, then that will cause suppression of the immune system and cause the tumor to evade the immune system even more. So the PS is, yes, it's a global immune checkpoint. It's an upstream one. And antibody-mediated blockade of PS signaling will break the immune tolerance to the tumor and reactivate the immune system to kill the tumor. But also, it can also break the immune tolerance to your self-antigen and induce autoimmune diseases. And that's the reason we need those antibodies to be getting into the tumor, not going everywhere. And using nanotechnology is one way of doing that. So yes, you would have a durable anti-tumor response. You would even have memories. You develop memories that will prevent the tumor recurrency, which is very important in managing cancer, because what we say the cancer, there's no cure. And why there's no cure? Because if you get rid from all this tumor, yes, and you get the remission, but you still have the genetics that can mutate, and then you have the tumor will emerge. Like patients with breast cancer. Why we say we need to take all the breast tissue out? Because if you remove that breast tissue that has the tumor, well, because you have genetic mutation in your breast tissue, so the other breast has a risk of developing the cancer, because we have the genetics that has a risk of mutating and become cancer. And that's why we remove the whole boat. We remove anything that has tissue of breast, so we can get rid from those tissues, because they have genetics that they are going to mutate and become cancer. But I think with this technology, and if we're able to create cytotoxic immune response, then I don't think we need to remove both breasts in the future, because then you have a robust immune system that if any of those breast tissues trying to become cancer, hey, your immune system will going to eliminate and destroy it. Possibly this will prevent us from just doing the mastectomy both sides if we introduce, and we know we have studies and results that shows that because if you take those blood from those patients, white blood cells, they're very rich with cytotoxic T cells, and if you put it in any tumor of the breast tissue tumor, they will destroy it. This is so here, this is completely different from what we have done before. What we have done before, we destroy the cancer cells, but we don't do much of enhancing the immune system with radiotherapy and chemotherapy. And that means the patient is at risk of having recurrent tumor. With this immune therapy, it's possible that this will secure and prevent tumor from recurrency, and this will help us not to have medical necessity of removing two breasts. But that needs to be studied and coming up with the studies and all that. This is just hypothesis for now. Maybe in the future we can prove it, or with all the therapies and all those clinical trials that's being conducted, and see the cases. If we do it with immunotherapy, is the recurrence is less than that what have been done before. Not so I think that's what's the future is, or the research is that's going to be conducted, and see the outcome of using immunotherapy combined with other therapies as well. As I said, antibody-mediated blockade of PS signaling breaks the immune tolerance, reactivate the innate and adaptive immune cells, which result in durable anti-tumor response in multiple preclinical models. So we're still working on getting the results out of those therapies. Combination of preclinical studies, combination of, as I said, the CTL, PD-L1, and PS, and chemotherapy, radiotherapy. I think it will have better results than doing it by itself. Again and again, how many people we have in this room now? Around 15 people. 50% of you have a chance of having cancer. It's a flip of a coin, or it's a coin toss. 50%. That's a big number. It's a big chance. It's alarming for me, and I think we're not doing too much in telling the reality and the truth to our patients, and we're not doing too much and lowering that chance from 50%. That's a very high. Think about it. You know, you're 50% going to have cancer. As a doctor yourself, don't you think now it's a time to look for the way that we can reduce that chance from 50% to 40 to 30 to 20, even for reducing it for 5%? That's accomplished. And as I said, they're trying to do it with vitamin D, and the mainstream medicine, they're recommending it 1,000 international units according to the Canadian Cancer Society, not the United States. The United States still behind. They're completely, they don't look at the supplements will prevent cancer. But as us, as integrative doctors, and combining the mainstream and integrative, we need to believe that adding polyphenols, adding spirulina probiotics to manufacture those polyphenols in your gut, so you have a constant production of polyphenols and chlorophylls, adding B17 in your supplement, and creating this cocktail together and become an essential thing. And again, those cocktails of polyphenols that we talked about, they're not just preventing the cancer, but also they are anti-aging supplements. They are also help to delay any triggering of those degenerative diseases. Like if you have Alzheimer in a state of starting at the age of 60, you will delay it to 70, or if you have Parkinson genetics makeup, you can push it farther with those polyphenols that we talked about. Cod liver oil, which contain the vitamin A and D, spirulina probiotics, which has all the soluble, water-soluble vitamins, along with polyphenols, and along with methylene blue. If we can create that regimen and it become medical necessity for your own family as doctors first, and then for your patients, and then with time we can find out if this will be an effective regimen or not by studying again, doing all the studies about the people who are dying and their history of being diagnosed with cancer, and whether they are taking polyphenols and the regimen that we're talking about or not. And then we can come up with realistic protocols that will be adhered and be compliant by the patients. And the only way you can tell the patient, this is fact, tell them, hey, you are my patient. I want to let you know that myself and you, we have a high risk of having cancer at any time in our life. And it is 50% reported by mainstream publications. And it's completely solid studies. This is, I think they started with 2015 and up to now. Before 2015, we have no clue about this fact. Then you can tell your patients, let's work together and providing you the supplement to help you to lower that chance. And also, if you have any degenerative diseases or autoimmune diseases, whatever that may emerge at any time, we can delay it farther with using this change in your lifestyle and your nutrition and your diet and the supplements that we think it will be the best for our health. And I think we're done. And if you have any questions, I'm open for questions.
Any questions? Are you still
Very
there?
good, Doctor. Yep. Thank
Okay.
you. Very good presentation. Thank you. We'll see what we can. People are have a lot of questions, a lot of things to ask about there.
Yeah, that was excellent. And again, I've got a lot to study, but I also learned a lot because this reinforced some of the things that I've learned previously through these meetings. And the language is getting, it's been burned into my brain. So, you know, TH1, TH2, Tregs, and just understanding. I don't have to think about it as much. The one thing I do have a list of different supplements, different things. This was actually from the Cyrex lab. They have a big list backed by data of different substances, natural substances that can upregulate, downregulate Tregs, upregulate Tregs, downregulate T17, upregulate natural killer cells. So, as I was thinking about it, because thymosin alpha, although it is FDA approved, thymalphasin is FDA approved in this country, is not available for whatever reason. I won't get into it, but I did see that vitamin C upregulates natural killer cells. So I never understood why vitamin C was used for cancer, but I can see that, and I'm going to dig into the data, to understand it more deeply. But I can see clearly that I understand why vitamin C high dose would be used, because if that is upregulating natural killer cells, well, that in essence would be upregulating Th1. So would that fit as well?
Yes. Vitamin C, high dose, not the low dose. Vitamin C high dose, we're talking about the IV ones, not the capsule that we're using. Even vitamin D, they help to polarize the immune system to Th1M1. And so giving it in high dose, not lower dose. Don't tell the patient you take the regular vitamin C orally and you get your polarization immune system. It has to be IV in a high dose. It generates, first of all, free radicals, because high dose vitamin C, they are oxidized form. Then they will generate hydrogen peroxides and generate free radicals in the tumor and kill the tumor. But also it stimulates the expression of interferon gamma, and it helps to polarize the immune system to Th1M1. The same like vitamin D as well. It does help to polarize the immune system to Th1M1. That's why it's good even for treating infection like COVID. COVID is similar to cancer in that way. So that's something you need to learn, that COVID is polarizing the immune system away from Th1M1. And this will cause the virus to flourish and replicate inside the cells without being bothered, because there's not much of cytotoxic T cells to be killing those infected cells. And that's the reason when we recommend our regimen is to give things that polarize into Th1M1, and ivermectin is one of them. Hydroxychloroquine is one of them. And that would help to eliminate those infected cells with those viruses, because those infected cells with viruses, if they continue, they can create variants, and you would end up with endless of pandemic. And that's the reason why those vaccines, they made with developing immune, which is antibodies, but they're not doing too much of cytotoxic T cells. And that's the reason why when we have the Omicron virus, which is a kind of a free life vaccine, the Omicron viruses, they don't really use the spike of the COVID. They use the spike of the flu because it's a hybrid. And that's the reason why this Omicron virus developed herd immunity that we're looking for to eliminate and get and end the pandemic. And because they polarize the immune system to Th1M1, and we got rid from all the variants. So this is the reason why COVID-19 is history, hopefully, and hopefully we'll not get any more of those viruses, mutated and emerged again from the lab. But I think that's it. We're done with it, hopefully. And now we need to move forward to the next chapter. So all the doctors who are treating COVID, now the disaster that we have is cancer. Not anymore. The number one killer is cancer. And that's the reason as CDP MCS physicians, we need to come up with a cocktail the same way we did for COVID for preventing cancer. And Mike Beamer, as a pharmacist, he's going to lead this project along with us as a physicians of CDP MCS. We're going to reshape the dynamics of health system by minimizing the risk of having cancer from the beginning, using a cocktails of polyphenols and vitamin D and vitamin A in a form of cod liver oil, spirulina, polyphenols we talked about, methylene blue, and start giving it to the patient. And that's the next chapter that we need to work on it together and help the patients, our patients who are being suffering. And the same cocktail of polyphenols that we talked about, it will help to even balance the immune system of the patient with post-COVID-19, because their immune system is being disturbed, their mitochondria, their endothelial function, and those cocktails will help those patients as well. So it's like hitting many birds with one stone, and a continuation of your legacy in enabling to control the COVID with understanding that when you give the ivermectin or you're giving methylene blue, you are working on inhibiting the Th17 and polarizing the immune system Th1M1. And the same concept can be done for cancer. Now, can I use ivermectin as prevention for cancer? No, because there's other drugs that can be better effective than ivermectin. And methylene blue is one of them, the polyphenols and things like that. So you don't have that red alarming and flags that you don't need it. But if some patient has cancer, yes, you can start using ivermectin and antifungal drugs and anything that helps to, which also repurposing drugs, to help to mobilize and polarize the immune system back to Th1M1.
And, I was going to say also too, I'm looking at this list. I've got vitamin D, vitamin A, upregulates T regulatory cells. So that would, I can see how cod liver oil would be perfect for that. And testosterone does the same thing.
Okay, I don't agree. Wait a minute. I don't agree everything that's cytotoxic. What is the name of the company?
Cyrex.
Cyrex. I don't agree everything that they are doing in their supplement. When you said vitamin D, right. So the very important is that they have to understand that vitamin D polarize or inhibit the Th17. And when you do that, you can use it for both autoimmune disease and cancer. So that's a very important message. Some drugs, like low dose naltrexone, you will see, oh, it's good for cancer. It polarizes the immune system to Th1M1. And it's good for autoimmune diseases because it polarizes the immune system to Tregs. How is that? Okay. The reason is, let me explain it very well, because what you're doing in both sides you have Th17 is a problem. Both sides, the Th17 polarization is draining the immune system away from Th1M1. Okay. And that's not good for cancer. So that's why we give vitamin D to inhibit that. Okay. What about autoimmune diseases? Autoimmune diseases, there is Th1 and Th17, and Th17 is not good as well. So that's the reason we're giving vitamin D. And understanding that, then you can understand why vitamin D works for both autoimmune diseases and cancer. Does that make sense?
Okay, so basically, just so I understand it better, by modulating Th17 and bringing it down, you would naturally be upregulating T regulatory. So it's not that the vitamin D or cod liver oil upregulates Tregs, it's that it modulates or downregulates an overactive T17, and thus the T regulatory as a result is upregulated. Is that a better way to see it?
Yes.
Okay.
So Cyrex, I know the guy. I mean the doctor. He's a smart guy and all that stuff. But I told those people to work with us so we can really solve this gray areas. And Dr. Patel, all the time, because she's very intelligent. Let me tell you something. Dr. Patel, she's very intelligent. She's very logic, and she is an INTP for sure. Okay, she's the same kind of personality of mine. she wants to know the reason, the mechanism of action. And if you say anything that's contradictive, then she will jump on you and start questioning you, and maybe she will not sleep all night thinking about that. And that's me, that's my quality too. So you know, when we talked about low dose naltrexone, Dr. William, and he say, well, we used for autoimmune disease and we used for cancer. Now that is like a shock for me. How that will work? And so I start looking and digging, and then we find out that the common pathophysiology of cancer and autoimmune disease is overactive Th17, and low dose naltrexone inhibit that, and that's good for cancer and good for autoimmune disease. And so I don't want to use polarization of Th1 and M1 well, automatically, if you inhibit the Th17, that's mean in cancer you are giving more immune cells to be polarized to Th1. And in autoimmune disease, if you have Th1 and Th17 overactive and you block the Th17, then you're decreasing the inflammation that destroys the tissue. But also you need to work on inhibiting the Th1 as well when you are managing autoimmune diseases. And that's why you need to give them thymosin beta or erythropoietin peptide in combination of vitamin D and low dose naltrexone. So this will help to polarize the immune system into Tregs and Th2 and suppress the Th17, Th1 in managing multiple sclerosis and rheumatoid arthritis. So you have to combine things together, not just one monotherapy. It makes sense?
Yeah, no, I appreciate the clarification. It's yeah, because I'm just going by the list here, but I can see, I understand what you're saying, and that makes sense. It totally makes sense. They talk about metformin down-regulating Th17. Is that?
Yeah, you can say that. Metformin.
Yeah.
Yes, metformin downregulates Th17. Hydroxychloroquine does that, the same thing. Ivermectin does that. Th17 is a bad thing when it's overactive. And most of disease out there, they have this component of Th17, and that's the reason we're giving all these drugs. But again, I talked to Cyrus and I told him to work with us so we can really give the right message. And if you're able to get them, I mean, he's interested. He say yes and all that. It's same like who's here, Dr. Cruz. Also, he's interested to move with us and all that stuff, but he needs to be pushed. Hopefully, that Mike Beamer will push him to join us, and so we can be one team. Are you there, Dr. Rafael? If you're there, I'm trying to push you to work with us.
Question, Dr. Halasa. If we're looking at like several of these drugs that that downregulate Th17, one of the questions that I'll inevitably be asked is how much of these is too much? Like, for example, if I give somebody hydroxychloroquine, is that enough? Or do I need to supplement that with, for example, some other agent? So how many multiple agents are advisable when we start talking about some of these interventions that involve nutraceuticals?
We'll give you an example. Let's say if I am going to manage multiple sclerosis, and multiple sclerosis, we know it's Th1 and Th17 dominant disease. It's not just one. Then I want to polarize the immune system away from Th1 and Th17 into Treg and Th2. And so if I give only ivermectin or hydroxychloroquine or any drugs that inhibit the Th17, low dose naltrexone, which is the best. Okay, I inhibit the Th17, but I did not do much in Th1. So I need to work on Th1, inhibit that, maybe using thymosin beta, erythropoietin peptide, and if not, then I can use polyphenols. Possibly that may help. Or you need to find a way to block the Th1 using possibly interferon gamma antibodies. That's what they are doing for multiple sclerosis, those immunoglobulins. And maybe that helps to polarize the Th2 into Th1 into Th2M1. But you cannot just block the Th17 only. And you cannot just block the Th1 only, because they did it. They gave interferon gamma antibodies, blockade. And what happened, you block the Th1, but then everything will move to Th17 and multiple sclerosis flourished. and aggravate the whole condition. And that's why they learned that there's something else besides Th1 as a pathology for multiple sclerosis. And that's where they discovered Th17. So you need to block the Th17, and there's blockade for Th17. There's antibodies that blocks the Th17, by the way. But the problem, again, giving those antibody blockades, it can cause immune intolerance to your self-antigens. That's the reason when you get into those antibodies, you need to really load them inside the nanoparticles, and possibly that may eventually help the whole case. Does that make sense?
Yeah, absolutely. Yeah, I think the answer is you have to do what you can. You know what I mean? Like what the patient can do and what's available to them and what's affordable. And, you know, because like you say, we're bouncing back and forth between drugs that could cost thousands of dollars and some that cost $5 or $10. So people are going to opt for those cheaper versions first, unless they're really, really sick, you know, and then the doctor will have to intervene and tell them what they need, basically. But yeah, one of the questions I know that will come up is if and it's a logical question, is if I want to do this intervention, which agent do I choose? And do I need multiple agents doing the same thing, working together? The answer to that is kind of yes, generally, yeah.
Well, again, your cocktail that you're going to develop, it's going to be, as I said, it's like many birds with one stone. If we're able to create the cocktail of polyphenols that we talked about, which is the main ones that's published, curcumin, ECGC, quercetrine, resveratrol, spirulina, caldivarol, methylene blue, low dose naltrexone, and we start giving it to the patients above 50 years old. That may help to reduce prevent the cancer and delay any emerging of all those autoimmune diseases or degenerative diseases, in addition to changing their lifestyle, because obesity is a source of Th17 overactivity and interleukin-6. And part of the pathology of obesity is that metabolic syndrome in general, they have too much of Th17 interleukin-6. So the lifestyle, the diet, and the right supplement cocktail would definitely help to reduce those risk of cancer and delay all those chronic disease that we can push it farther to 80s and 90s, and maybe they die without any of those conditions.
I think we could come up with a protocol. It would be a combination of prescription drugs and non-prescription drugs, but you could certainly put together that protocol, and I'll be happy to do that. Yeah.
Right. Any other questions? Dr. Patel, do you have any question? Dr. Cheryl?
Yes, where
you?
does losartan fit?
So again, do you remember when I said that those cancer cells, in addition that they are, the PS is polarizing the immune system to MREGs and M2, as you saw from the lecture, but also if the tumor itself, they express too much of, they overexpress too much of angiotensin 2 type 1 receptor. Do you remember that?
Yes,
and when those cancer
yes.
cells, they express that, then the downstream of it is production of interleukin-6. And then interleukin-6 will polarize the immune system Th17. Interleukin-6 will cause stimulation of fibrosis, cause the fibroblasts to start producing all those fibrosis, which will squeeze those blood vessels, preventing the T lymphocytes infiltrating the tumor, and then you have cold tumor. And so losartan will work very well here. It has an anti-cancer effect by blocking the angiotensin 2 type 1 receptor. And angiotensin 2 type 1 receptor, in addition to fibrosis and polarization of immune system to Th17, which will exhaust the immune system, and it also, as I said, produce the fibrosis that pressure the blood vessels, and you have that vicious circle, and activate the platelets as well. And then you have the platelets covering those tumor cells and shield them from the T lymphocytes and those effectors. So adding losartan, doing shockwave, using photodynamic therapy, doing methylene photodynamic therapy, doing radiotherapy, doing chemotherapy, doing antibody blockades, very important to nano those drugs. I would not like to give naked chemotherapy and antibodies. I would like to nano it as much as we can, so we can get them into the cancer, so we don't trigger autoimmune disease, which will drain the immune system again and will lead to tumor to flourish as well. So that's what we don't want, and that's the future of medicine, and that's the direction. There's big pharma already doing it for antibodies, by the way. It's called Scylla Therapeutic, I think, but they are making their platelet nanoparticles more stable by adding PLGA in it. And I congratulate the people who are behind this technology.
Do you have to avoid phosphatidylserine supplements then because of this
Well,
phosphatidyl?
we'll not do much. If we find out what will intercept the signaling, the downstream signaling of PS, something we may look at, and I think Dr. Patel and you, if you can start searching of what is the supplements and drugs that will inhibit the signaling of the PS. Now, we're blocking it from outside, but can we block the pathway and signaling of the PS from inside? That's something you may consider, but still, that's a problem as well, because if you do that, then you stop getting rid from the aged cells. And there's a side effect of it, because now if you block the PS signaling, then you're blocking getting rid from those aged cells and those senescent cells, and those senescent cells can become inflammasomes, and they can be and they can aggravate inflammation. They can cause Alzheimer, dementia, Parkinson, and so they have some. See, that's the problem with physiology. If you block this, you may end up having problem here. But so what you need is that find the way it's going to be injectable supplemental drugs loaded with nanoparticle and get them as much into the tumor versus to the normal tissue. That's maybe the answer here. And it's all about, weighing the cons and pros. And that's where you make that decision. But if you can come up with the PS signaling inhibitors as an injectable form and load inside nanoparticles, I think it's a good thing to do in managing cancer.
And just to clarify, we're talking about phosphatidylserine supplements versus phosphatidylcholine.
Yeah,
correct?
phosphatidylserine. See, the problem is not giving phosphatidylserine, because you need to block the signaling of it. So normal cells, they are inside the inner layer.
What I was trying to
So
what I was trying to say, sorry to jump in here. What I was trying to say is I'm not familiar with phosphatidylserine supplements, but I am familiar with phosphatidylcholine.
It will not affect the cancer here. Will not to grow, because the problem is not we have already phosphatidylserine inside the cell inner membrane, and the problem is when they flip outside and they become eat me signal, which is good for getting rid from aged cells and senescent cells, but it's not good when the tumor is using it to polarize the immune system to mReg M2. And that's where you need to consider how we can block the signaling, because if you restrict it from diet from phosphatidylserine will not do much. But if you can block the signaling and blocking in the tumor versus the normal tissue, then it's a win-win deal for those cases. And that's where you, maybe Dr. Patel, will investigate and see and look for those drugs, whether it's pharmaceutical and maybe like Beamer also. And that's the reason. Now, I lay down the foundation here, but I need you to contribute by adding more to what we learn, so we can learn from each other actively. This is the whole thing. It's just more or less those meetings is stimulating us to looking for more better answers, and then learn from each other. So I would like next week will be somebody else presenting and adding to what we learned this week, and do the same thing for the other weeks. Is that something you want to ask Dr. James?
Oh, that's perfect. Thank you. That's excellent. And guys, I have got my fill for tonight. Dr. Halassa, that was fantastic as always, and thank you.
Sure. What about you, Dr. Patel? Are you there? Dr. Ross, Dr. Cruz? Dr. Colleen, Anita. Anybody has questions? Everybody's happy? Dr. Klatz, Dr. Any questions?
Yeah, good job, Dr. Halassa. Yeah, I think everybody's brain is twisted into a pretzel after all that. That was an excellent presentation, and I learned a lot, and I have a better understanding of cancer. And I'm shocked or struck by, I was just doing a bunch of looking at viral infections and warts, HPV, and it's amazing how similar some of the processes are between what how viruses and cancers exploit the immune system of the host in such interesting ways. But it was great to look into that for tonight. And if anybody didn't have any questions, this reaches our 10 o'clock time where we usually try to cut it off. And if not, no more questions, we'll talk to y'all next week and look forward to that and mull over this interesting topic. I will try to put together the things that Dr. Halassa has talked about in a reasonably priced package and see what that looks like. And we can go from there.
Yeah, and try to help me to get more doctors on the board by inviting your colleagues and contacts, because it's a teamwork. And also try to help me up to work with the companies who are sponsoring us. Doing that, because we're doing it for free. I'm not charging anybody here, more or less. But I'm encouraging you to work with the sponsors of this meetings. The more you do that, the more we can continue doing what we're doing. And I'm trying to create that environment and education program where we don't charge doctors as much as we can. We charge what the companies, if that's possible, as they are sponsors. And Amex Pharmacy is a sponsor. Pharmanex also, they have a good system. Also, if you want to work with them, helps to screen your patients with carotenoids. He's here. Spirulina with Ross, Jamie, I want you to work with them like Beamer, reach out to him and see how you can get his in a state of him shipping from.
We talked about that tonight. Yeah, we'll be able to.
So try to reach out to him and have his, and again, this is what we talked about, Dr. Klatz and I today, is that we don't need to tell them to take them every day, because this is genetic material that you're giving, and they are expressing it and growing inside the gut and producing, and it costs too much. Like $5 per day is too much. So if we tell the patients, okay, you can take it once a week or twice a week, then that will reduce the whole thing into $30 a month. And make more sense. Using it every day does not make any sense, because you are seeding genetic materials into the gut, and those bacteria are expressing those polyphenols and those chlorophylls. There is no need to give it every day. And if you say every other day, that would be great. And then again, with this system of Pharmanex, will help to screen people with carotenoid deficiency. And it's very critical, because if you have carotenoid deficiency, you have malabsorption, right? And then you have high risk of having cancer. And this is a fast screening that you can do. The screen, I like the screen. And then if you don't want to use their supplements, that's fine. You can still work with Mike Beamer and use his supplements that's pharmaceutical graded. So if you have any questions, otherwise we will be ending the meeting today.
Yeah, no, very good. Well, thank you, everybody. Appreciate
That was great. Thank you. Good night, everybody.
Yep, see you all.
Excellent. Thank you.
All right, take care. Good night, everybody.
Good night.
Good night. Bye.
All right.